Can the next presenter please take up to the next podium? This is Dr. ASHISH KHODIFAD, right? Yeah, we'll have Dr. Kanchan or Sainani on the right side.
Good afternoon, everyone. Diabetic retinopathy is a leading cause of vision loss worldwide. Diabetic macular edema is one of the most common cause of vision loss in all these patients. Management of diabetic macular edema is guided by various landmark trials, but still we come across many case scenarios which pose a diagnostic and therapeutic challenge. So case 1, a 47-year-old Indian male presented to us with complaint of defective vision in left eye since last 1 month, known case of diabetes since 15 years with good glycemic control, and stable moderate NPDR since last 5 years. Best corrected visual acuity 6.6 in right eye, 6.9 in left eye with normal anterior segment examination. Fundus examination showed a pocket of subretinal fluid which was confirmed on OCT. Diagnosis of moderate NPDR with DME was made and we decided to go ahead with intravitreal Avastin. Despite giving multiple intravitreal Avastin injections and 1 intravitreal IVTA, the subretinal fluid seemed to be consistently increasing over the period of next 12 months. We decided to do a FFA at 8 months after presentation, which did not show any significant leak which can account for the amount of subretinal fluid which was seen clinically as well as on OCT. This is the fundus photo after 3 Avastins, 1 IVTA 12 months after presentation, showing pocket of subretinal fluid which was confirmed on OCT. Case 2, a 63-year-old Indian male presented to us with complaints of defective vision in left eye since last 5 months, known case of diabetes since last 20 years. BCVA 6.9 in right eye, 6.36 in left eye, nuclear sclerosis grade 2 in both the eyes. Again, pocket of subretinal fluid clinically confirmed on OCT, and diagnosis of moderate NPDR with DME made and proceeded with intravitreal Avastin. Again, after multiple intravitreal Avastin injections, the subretinal fluid pocket seems to be persistently increasing and not responding. This is the fundus image and the OCT after 3 Avastins showing similar picture. FFA, which was done at 6 months after presentation, did not show any significant leak at macula which can account for the amount of subretinal fluid. Case 3, a 48-year-old Indian female presented to us with complaint of defective vision in both eyes since 1 month, known case of diabetes since 15 years and history of weight loss of 15 kgs in last 1 year. Best corrected visual acuity 6.18 in both the eyes, rest anterior segment within normal limits. Fundus examination again showed a pocket of subretinal fluid, hard exudates confirmed on the OCT. Diagnosis of moderate NPDR, DME, decided to go ahead with intravitreal Avastins. Again, despite multiple intravitreal injections, Avastin as well as IVTA, the subretinal fluid seems to be persistently increasing. And this is the fundus photo which shows tortuous engorged veins along with pocket of subretinal fluid which was confirmed on the OCT. So the challenge in all these 3 cases was, what is the cause for the non-response? Are we really missing something in all these cases? So we decided to go ahead with the systemic workup, which turned out to be normal except for total proteins, serum globulin and albumin globulin ratio. Patient was referred to physician for further workup for hyperviscosity syndromes, who did serum viscosity, immunoglobulin levels, protein electrophoresis, bone marrow biopsy, and the results were surprising. Case 1 turned out to be multiple myeloma, and case 2 and 3 turned out to be Waldenstrom's macroglobulinemia. So the complete picture was NPDR with paraproteinemic maculopathy. Paraproteinemic retinopathy is caused by various paraproteinemias like multiple myeloma and Waldenstrom's macroglobulinemia. It is characterized by hemorrhages, venous engorgement, and serous macular detachments. Its differentials include diabetic retinopathy, hypertensive retinopathy, CRVO, and CSCR. But the characteristic feature of this paraproteinemic maculopathy on FFA is SRF is not equal to the leak. This is case 2 after treatment, where you can see patient was started on chemotherapy. After treatment, amount of subretinal fluid was decreased in right eye, but left eye, subretinal fluid does not decrease much, and there is deposition of subretinal hyperreflective material. Case 3 after treatment shows decrease in amount of subretinal fluid, but still it does not go off completely, and some SRF is still persistent. The practical problem which we faced in management of this patient was whether to go ahead with plasmapheresis or not, because from ophthalmologist perspective, plasmapheresis is the best treatment for maculopathy, but for physician, maculopathy is not at all an indication for plasmapheresis. Another practical problem we faced was communication. Patient came to us for low vision. He spends time, energy, money for 8 to 10 months, multiple intravitreal injection, but vision never improves. Finally, we tell him that you have got blood cancer. And then we finally tell him we don't know how to go ahead for the treatment of your eye condition because our and physician's view are conflicting. So effective communication is very important in such cases. Paraproteinemic macular retinopathy, it mimics other retinal vascular disorders. It can coexist and can be masked by them, and atypical behavior of any other common retinal vascular disorder should arise suspicion and prompt workup, especially in view of the life-threatening nature of these conditions. Thank you.
Thank you for the nice documented cases. Would it have made a difference if you had done the FFA much earlier rather than wait for 8 months?
Yes, probably it would have made a difference, but still, actually we were not aware of the entity, so even I would say that FFA in first case, it was done at 8 months after presentation, but by the time we did a detailed systemic workup and diagnosis was made, it was 12-13 months.
No, what I'm saying is in the OCT you do find fluid, but there is no corresponding FFA findings.
Yes.
So which should make us think that we are missing something. So
Yeah,
either you have to
definitely,
change the medication from anti-VEGF to something else, or think of doing an ICG angiogram to see if you are missing something. That's what I
Yes, sir, definitely, sir. It would have made a difference, sir.
Are there any biomarkers, imaging biomarkers from your cases that once you see them, you would think of paraproteinemic retinopathy
Yes,
in future?
yes, ma'am. I would like to show you. Can you project the slides, please? Yeah. Okay. It's not moving. Yes, ma'am. Here, as you can see, ma'am, in literature, not in some of the reports, they have described that this elevation, in this angulation, at like kind of acute angulation, they call it stalactite-like projections. So in case if you feel that, especially in CSCR, it would be smooth dome-shaped. But if you see that this elevation, it is in a kind of acute angle with RP as well as over here, then they call it stalactite-like projection. And a stalactite-like projection, it may be a clue that this is something different and it is probably paraproteinemic maculopathy. So stalactite-like projection, it is one biomarker, and FFA, SRF is not equal to leak, is the another biomarker.
Thank